All right, our next speaker is Dr. David Howell. Dr. Howell is the lead researcher at Children's Hospital Colorado Sports Medicine Center and assistant professor of orthopedics at the University of Colorado School of Medicine. He received his PhD in 2014 from the University of Oregon and completed a postdoctoral research at Boston Children's Hospital in 2017. Primarily, his research investigates the topics of pediatric concussion and human movement analysis. He has authored over 100 publications in peer-reviewed journals within the topics of sports medicine, biomechanics, neuroscience, rehabilitation, and pediatric medicine. He received the New Investigator Award from the National Athletic Trainers Association in 2019 and from the American College of Sports Medicine in 2020. His Twitter handle is @HowellDR. Without further ado, Dr. Howell.
Thank you so much, and thanks everybody for the, or thanks to Precision and Megan for the invitation on this. I'm excited to be back talking, sounds like primarily to a Northeast audience. I'm out here in Colorado, so it's just 10 o'clock in the morning for me. So I apologize if I go over into your lunch breaks. The good news is my internet seems to be holding strong. I'm gonna present now. If it doesn't, Tom, I'm gonna count on you to text me and tell me if I'm talking into the void, because that happened multiple times here. All right. So now I can't see what exactly I'm presenting. Are you seeing my slides there?
Yep, you're good.
Okay, perfect. All right, so I'm gonna kind of take what Dr. Buckley had talked about on well, kind of a different topic. Sorry, I'm just gonna reformat a few things here so I can actually see what I'm doing. All right, awesome. So Dr. Buckley is talking about kind of the long-term effects, you know, from playing youth sports, football in particular. My perspective is much more on the acute injury of the clinically diagnosed concussions, and what I would call kind of short to maybe medium-term effects. So one of the outcomes that kind of understood over the last several years following a concussion is you may be more likely to sustain a musculoskeletal injury. So how does the brain injury affect movement and risk of future injury, particularly in athletes? And again, I'm at the Children's Hospital in Colorado. I was at Boston Children's Hospital prior to this. And so I'm kind of mostly going to speak from a pediatric perspective, but there is a little bit of, I would say, collegiate athletes as well. So kind of moving from this repetitive head trauma to the acute diagnosis of concussion. Nothing in my talk is going to really peddle any sort of product, but these are my kind of research support mechanisms, a few grants from NIH and from a Colorado brain injury grant as well. So when we're talking about kind of injury prevention in the large context, and we identify that there's a problem and there's something that needs to be fixed. This is the model that was put out by Van Mechelen in 1992. So what is the extent of the injury that's happening? So that's kind of answering the what. The second part, once we understand that there's a high incidence of different types of injuries or a specific type of injury, we want to answer the why. So let's establish the etiology and the mechanism of injury. Once we understand that mechanism of injury, then we can introduce preventative measures, and that's the how. And then we test those and go back to step one. So that's kind of the framework that I want to talk from today, because those three topics kind of align with the three different kind of objectives that I want to talk about over the hour. And maybe what I'll do is I'll kind of start with step one, and if people have questions, we can stop and discuss a little bit. Same thing for step two and step three. So the objectives are, number one, let's describe the existing literature and some of the theoretical kind of concepts around why athletes may have an increased injury risk after a concussion. So that's the what. Number two is let's summarize the potential factors that contribute to this injury risk. Now, we don't know them, but there's a couple kind of theories that we'll go into. That's the why. And at the end, I'll present kind of some pilot data and some things that we're thinking about as far as exploring ways to detect and intervene on this risk of injury in this potentially vulnerable population of athletes post-injury. So that's kind of the framework for the next, I don't know, 40 minutes or so. We'll see how long. And again, feel free to speak up and interrupt me if anybody has any questions. So again, we're not talking about repetitive head impact. We are talking about acute sport-related concussion primarily in this talk today. I think as clinicians, it's fairly easy to spot the super big hits, the loss of consciousness. We can identify if an individual is down and if they have some kind of overt signs and symptoms of a concussion. But as we all know, it's not that easy 100% of the time. Symptom scales we rely on quite a bit, and I think that they're valuable because at the end of the day, we want our patients to feel better and not be suffering from headaches and dizziness and poor sleep patterns and all those kinds of things. But we also know that they're subjective and they're not specific to a concussion. If you're yawning right now and you're fatigued, you're tired, that may have to do with a lot of things. Probably, hopefully, isn't because you got hit in the head yesterday, but it can result after a concussion, right? So it's non-specific to concussion. Athletes are this tricky population where some of them may underreport their symptoms. I think we see that we see that commonly where people want to go back to sports because that's what they do. They want to not let their team down, et cetera. But we also see kind of over-reporting symptoms in some of our clinics where athletes are actually scared to go back and they are kind of feigning their symptoms and they're saying, oh, you know, I've got all these problems that may or may not actually exist. So we can't solely rely on symptoms. And then the third thing would be that even if somebody's telling you the truth and they say, yes, I'm 100% better, my symptoms are completely resolved, let's assume that they're telling you the truth. That may not reflect physiologic healing of the brain. The physiologic restoration of the brain has not potentially fully occurred, even though they perceive that they're all better. So these are just kind of some of the potential domains that are kind of wrapped into this. Same points, but you know, we kind of tend to group them in different categories as somatic, emotional, cognitive, sleep, things like that. I think I just put this up here to kind of illustrate that concussions are complex. They are challenging to understand, and this is kind of a very simple diagram of all the different potential symptoms or systems that a concussion can affect. And I'm going to kind of focus mostly on the balance, posture, sensory motor, so kind of these subcortical systems. But I only say that because there's a lot of other systems that may be at play and contributing to the things that we're going to talk about today. And then we know that returning someone to play after concussion is not that easy. This is a framework put out by Jeff Kutcher and Chris Giza a few years ago that I think is good in a lot of ways and really just demonstrates the complexity of the return to play decision. You know, if you suspect a concussion and you remove somebody, there's maybe not a definite, but there's a probable concussion. You want to continue to assess them until their signs and symptoms go away. You do graduated exertion and you return them to play. Now, what I'm going to focus on today is really that return to participation. So an athlete has gotten a concussion, you've cared for them, they say that they're better, you put them through the stepwise protocol, graduated exertion, and you say, okay, now you're cleared to go back to play. By all clinical measures, they're fully recovered. How do we truly know if that athlete is ready to return to a sport? And if they're able to fully kind of prevent themselves or are they fully equipped to prevent further injury, whether it be a concussion or an ankle sprain or something else? And, you know, as clinicians, that's a very difficult but necessary question, I think, to wrestle with. You know, how do I know that I'm not doing this person further harm by putting them back out on the soccer pitch or the football field or something like that? So how do we do this? We've got several different clinical assessment methods, and I'd say there's probably kind of 4 domains that are common, one being the SCAT-5. And as an aside, I just bring up the delayed recall memory from the SCAT-5 because it's been in the news lately. I think most of us know, but you want to be sure that the 5 words that you choose have different kind of meanings, right? You don't want to have 2 things. For example, just pulling out of my randomly, man and woman, those 2 things are related, so you shouldn't use those 2 things together in the 5-word list. Also point out that we've moved to a 10-word list within the SCAT-5. This is different than the MoCA. But the 10-word list was kind of introduced with the SCAT-5 because there were some ceiling effects. And And the 5-word list was potentially too easy for acutely brain injured people. They were getting it right, or potentially at baseline. And so to increase the complexity, you ask somebody to remember more words. That's my one aside, has nothing to do with anything in the news right now, I promise. The other things that we commonly use as clinical assessment methods: computerized neurocognitive testing, the balance error scoring system, vestibular and motor screening. I think these are all great tools because they capture different domains, but then they also are pretty relatively easy to do. Most of us probably have some experience performing or administering a BESS or a VOMS test. At the same time, the data from the CARE consortium that Dr. Buckley's a part of has been really instrumental in informing some of these things, right? Yeah. So, you know, I think that what we're learning about these tests.
I thought I had an appointment with you yesterday.
Sorry. Somebody. Oh, okay. Sorry. Maybe somebody was on mute or off of mute. The thing about these measurements is that while they're clinically feasible, they may not be reliable enough for us to truly depend on them, right? This one study from a couple years ago, one of the first CARE consortium studies, showed that essentially all of the measures that we use, the impact vital signs, COG state, VOMS, King-Devic, SCAT, different symptom inventories, global life satisfaction, those types of things aren't super reliable when you serially assess somebody year after year. So what do we do? Okay, so then let's go to the other end of the spectrum and really understand in depth the different areas of the brain that have dysfunction. We can measure with great precision using things like transcranial magnetic stimulation, potentially blood biomarkers, diffusion tensor imaging and advanced neuroimaging, and EEG. All of these things I think are very, very useful to help us inform how the brain recovers after a concussion. And this systematic review from 2017, if you're interested in this, is a really, really great paper. The main finding being that the time course of recovery for different physiological parameters exceeds clinical recovery. So we have these measures that we do clinically, but we can continue to identify deficits that persist using these more advanced techniques. But at the end of the day, as an athletic trainer or physical therapist, in your setting, I imagine you're not going to deploy any of these on a routine basis, right? They're expensive, they're time consuming, and they require a lot of a high level of expertise in order to actually get anything meaningful out of them. So how does this then relate to the existing literature surrounding the increased injury risk after concussion? Well, if there's some sort of deficit that exists and we can measure it across multiple domains, but our clinical tools aren't sensitive enough to pick up those small potential neurological deficits, maybe those persistent deficits are predisposing our athletes to further injury. And so, you know, coming up with different types of assessments that actually get at that, I think is an important next step for us. So we're going to kind of switch gears a little bit and talk about the what. So what exists in the literature related to concussion and increased injury risk? So the real question is, you know, these two injuries happened, I think, years apart, and most of the data that we have is within 1 year. But if you get a concussion and you have altered mental status, a diagnosed concussion, maybe you're bleeding from your ear, you know, in the year after that, once you've been cleared to go back to play, are you more likely to sustain an ACL injury and then miss a full year after that? What does the data tell us? So there's 2 systematic reviews on this topic right now. And if you're familiar with forest plots, they're great. If you're not, no big deal. The main things to kind of focus on here is that they summed, this top one summed 5 different studies, the bottom one summed quite a bit more, but they compared individuals who had a concussion and went back to play and their injury rate versus those who did not, controls. They did not have a concussion. What does their injury rate look like over a year time? And this first one found about a 2.1 greater odds of sustaining a musculoskeletal injury in the year after a concussion compared to those who did not sustain a concussion. And a little bit bigger, but I would say a little bit more encompassing of different types of studies, found the same thing and actually found about a 2.5 greater odds of going back to play and sustaining a musculoskeletal injury. And there's different, with meta-analyses, the limitation is there are different definitions of what that means. What is a time loss sport-related musculoskeletal injury? Most of them are lower extremity injury specific. And that's kind of what's informed the theory to this point. But there are kind of variations from study to study. The other thing I want to point out is that the data thus far is not super representative of the population. So here's a handful of studies that I've identified, and you can. I'm happy to send papers to people or whatever if you want to read a little bit further. And I'll go into some of the data on a couple of these studies in a second. But these are, I think the thing to take away from this, number one, is this phenomenon has been documented in the professional and military kind of group, in collegiate athletes, and in the high school / kind of recreational athlete group. But I think the thing to consider in addition to this is that women and girls only represent about 12–13% of the subjects who have been included in these investigations. You can see of the active duty soldiers, this is probably biasing this that statistic quite a bit, but most of them were males in this really, really large study. And then all of these other ones, there's a decent distribution, but there's kind of a male-heavy presence, which kind of reflects a lot of the concussion research in its kind of infancy. It happened in collegiate football players. And so I think something just to recognize is that, yes, this exists, but it's primarily collegiate football players and military personnel who are male. So just, again, kind of a limitation of the research and something we need to get better at as a research community. A couple of specific studies. This is from Rob Lionel. This is one of the first ones that showed you're looking at injury incidents per 1,000 exposures. And so what he found, and I think the most important thing is this risk ratio here, was that before somebody sustained a concussion versus after somebody sustained a concussion. They looked at an electronic medical record and looked at the year before and after. There's a significantly higher incidence of musculoskeletal injury after the concussion relative to before, no difference in a control group. But what's interesting is kind of one of the theories is, well, you sit out from sports for a month or however long to recover from the concussion. It's probably in that first week to month that you're kind of more inclined to sustain another injury because you're deconditioned. If you look at the p-values, and you can debate the merit of p-values, but the significant data points were actually about a half year to a full year. If you look in that first 90 days, the risk ratio is actually the highest, but we're less confident in that, so it's not a significant difference before versus after. So I think something to understand, something to consider, that it's not an immediate effect. It seems to continue on for a long time. This is another study of professional rugby union players out of, I believe, out of Wales. And what they found was this very similar finding that if you sustain a concussion, go back to play, you're more likely to get another injury. They found actually a 60% greater risk of a time loss injury after a concussion. And then this is the large scale military study, and they found, again, a significant relationship between sustaining a concussion, going back to military duty, and getting another or getting a subsequent lower extremity injury. And they actually broke it down by different types of body parts. And so you see a little bit higher of a injury rate in the hip, a little bit higher in the lower leg and ankle, a little bit higher in the knee, a little bit higher in the foot. So, and maybe a little bit higher in the upper leg and thigh. So at each body part, it wasn't a specific ankle injury only, but the summation of that is kind of this really big discrepancy. It looks like about 23% versus about 18%. So if you get a concussion, about 23% of these military personnel went back and got a lower extremity injury versus maybe about 18% who did not sustain a concussion. So kind of a summary of the literature to this point, and I just picked out some studies that I like the figures and tables, and I think they're easy to understand. There's a lot more literature on this, but around a 2 to 2.5 greater odds of subsequent injury after concussion. Number two, again, this phenomenon is present, has been documented in various age groups and various skill levels and professions. But again, there's that large discrepancy on females to males. So I think further research is needed just to see the generalizability about this. We move on to number two, which is kind of, okay, so this exists, now the why. Does anybody have any questions at this point? Perfect. Just wanted to open it up, and again, feel free to put in the chat if you do. All right, so let's go back to this kind of example. We know that our clinical tests have a less than optimal reliability for most common and emerging concussion assessment tools. We know that we can measure recovery for a period of time that exceeds clinical recovery. And again, I'm calling clinical recovery kind of those examples on the left. And there's a discrepancy there, right? So the question then becomes, are deficits present when athletes are cleared to return to play? So when you do your clinical assessment, you say you're fully cleared to go back to sports, are they truly prepared to meet the demands of sport? How are you testing people? What are some things that we can consider? And then how does that relate to kind of further injury? So related to musculoskeletal injury, this is a study that was published this year by Dr. Buckley. I think this is I know that he's on the call. I would say this anyway. I think this is a really well done study because what they did was, first of all, they looked at a cohort of collegiate athletes from the time that they were cleared to return to sport over the following year and looked at, okay, is there a significant effect of having a concussion and being at a greater predisposition or vulnerability to a subsequent musculoskeletal injury? The answer, aligning with all the previous research, was yes. So I think that that's step one, and that's a really great kind of, okay, we've got a cohort, we know that this phenomenon exists. The question then becomes clinically, okay, what tools can I use to actually identify this risk? Well, they looked at a whole bunch of different clinical outcomes and compared them between the those who did and did not go on to sustain a lower extremity musculoskeletal injury. So that's total symptom score, that's the SAC score, their best score, both on firm and foam, I believe. The computerized neurocognitive test, this was IMPACT, and the King-Devick test. So surely one of those or some combination of those is going to allow us to identify, okay, yes, there's a persistent effect, and this particular domain is something that may be sensitive to further injury. And what they found was actually no, none of them were. Nothing predicted whether or not somebody was going to sustain a musculoskeletal injury using this nice battery of common concussion tools that I'm sure, like I mentioned earlier, are commonly used among most of us. So the main finding of this is that the clinical measures we use are not equipped to predict musculoskeletal injury after concussion. So then this brings us to like a conceptual theory. This isn't published. This is just kind of my way of thinking about it. And again, there's a lot of different theories and people have different thoughts, and there's probably a lot of things that I'm not considering. But what are some of the things that might cause a musculoskeletal injury increased risk after concussion? Well, the first two things that we've done a lot of work on is that perhaps there's lingering motor deficits and or attentional deficits that are persistent for individuals beyond clinical recovery. If we look, kind of take a step back from just the concussion literature, and we look at the literature at large of just injury risk in athletes, we do see that those with some sort of motor control problem or neuromuscular control impairment, as well as those with attentional difficulties or attentional deficits, they're more likely to sustain a musculoskeletal injury risk. So that's just kind of inherently. Now, if we bring that into the context of a concussion, we know that concussion causes these deficits, or is at least associated with these deficits. It may be that those haven't recovered by the time we clear people to play, return to play, and that may predispose them to further injury. And I'll get into a little bit of kind of some of the work we've done on that in a few slides. As I mentioned earlier, I think one of the, maybe not documented, but in a lot of the conversations I have with folks, this is always the thing that they say, well, you know, the deconditioning, somebody's out of sports for a couple of weeks, they go back, they're not equipped. I think the data that I showed kind of somewhat refutes that, although not convincingly. But at the same time, I think our return to play protocol helps address a lot of that. We're not sending somebody back to play, you know, oh, you're symptom free, you cleared your tests, go back and go play on a Saturday in a football game. I think we instead have to think about, okay, you know, we're adequately preparing people, their steps along the way to actually get them back up Now, conditioning from an aerobic exercise standpoint is something I think that we focus a lot in concussion rehabilitation. But on the flip side, the conditioning of the neuromuscular system is something to consider as well. And I'll talk about that in a little bit also. A couple other theories that I don't think I have time to get into today, but happy to send along the papers. There's a group out of the University of Pittsburgh that has done a lot of really, really great work on the disruption of perception and action coupling, and how there may be some disruption to how you perceive information and how you act upon that, and that coupling mechanism may be the thing that predisposes people to further musculoskeletal injuries. And then a couple other things that may just be inherent to the individual. So the things that predispose you to getting a concussion could also be the things that predispose you to getting a musculoskeletal injury. So you might just be one of those injury-prone athletes, and those athletic trainers in the room, I think, can relate to those individuals who are oftentimes on their table more often than not, and for whatever reason they're legitimate injuries, but they're just always getting hurt. And then the other one is risk-taking behavior, right? So if somebody has a propensity to put themselves in harm's way, it's likely that they're not only going to get more concussions, but they're going to get more musculoskeletal injuries. And determining kind of that time sequence, I think, is really important, and something that a lot of the research that's been published and people are working on are set out to determine. So what are some of the things that we're doing to try to identify some of those mechanisms? So a lot of the work that I've done is on kind of dual tasks. So when we test somebody and they're returning back to sports, we usually use kind of all these different isolated type tests. So we'll, I don't know how many people do a gait examination, but some sort of isolated motor task, whether that's the BEST or a Romberg test or something like that. There's a little bit of a vestibular component, certainly a neuromuscular control component to maintaining stability during that test. And then we'll do an isolated cognitive task, a computerized test. Look at shapes, remember them. But how many times during sports are individuals actually sitting in front of a computer screen, right, clicking buttons? Or how often are they really isolated in one domain or the other? And the nice part about dual tasks and multitasks, kind of layering tasks on top of each other from different domains, is you can measure them independently, but then you can measure them once they have to do two things at once, right? So it's more of a reflection of the on-field demands that athletes are about to go perform, where they have to rapidly integrate motor and cognitive data. And the paradigm that we've used a lot is gait, because it's a fairly reliable and measurable motor task that most people kind of have an inherent program. And you can measure how fast somebody walks, for example, under kind of unconstrained and undivided attention conditions. And then you can add a cognitive task on top of that and see how they respond. How much do they actually have to slow down when you add a single cognitive task on top of that, let alone the complexities of sports? And I think this is a good example. I stole this from Rob Lionel at the University of Georgia, who I think stole it from Twitter from a soccer club in somewhere in Europe. And I think that this was from the perspective of don't yell at your kids while they're playing soccer because they've got enough on their minds. But I'm going to kind of borrow it for athletics and thinking about this is not just movement. So you think about a soccer pass and the many different cognitive and motor demands that are required. So I'm telling, or my brain is saying I want to pass something, but can I go far enough? Can I get it successfully? Where's my teammate going to be? Where are the defenders going to be? What part of the foot am I using? When am I going to do it? Who's making a run? And how do I get it to them in the proper way? Where's my position in relation to somebody else's position? So you have this kind of spatial orientation aspect, but then you have to execute a motor program to kick the ball to the appropriate spot on the field. But you also have to use all of that cognitive information and process that information very rapidly, and execute that in a way that the person is actually going to receive the pass, for example. And so I think that we need to consider that athletes are doing way more than just moving or thinking independently. They're distributing their attention across all these different internal, external stimuli. And I work with high school kids, and those of you that do know that it's never just about the game. maybe they're trying to impress somebody up in the stands, maybe their dad is yelling at them, maybe they're, there's a lot on their minds as they're trying to execute these things. You put them on a field after a concussion, and if their attention is not able to kind of be distributed at that very rapid pace, will that predispose them to not being able to react to something in an appropriate manner, and potentially putting themselves in a vulnerable position for further injury? Once they distribute that attention, now they have to actually select appropriate motor responses, and then they have to rapidly implement those. It's not just a one-time thing, right? You have to continually be monitoring that and rapidly implement that. And that takes a lot of cognitive effort in addition to the neuromuscular effort that is required by these sorts of tasks. And I think sometimes, we kind of become immune to the complexity of how difficult it is, particularly, for example, at the Division I NCAA level, the complexity of the motor tasks, but also just the skill at which they perform these tasks requires a lot of brain and muscle kind of brain-body interaction. When it comes to injury-prone athletes, kind of the next point along here, again, this is a theory. There's one study that showed that those who have a concussion and have an ankle injury, for example, they demonstrated essentially similar kind of patterns before and after the injury when it comes to their risk of sustaining a musculoskeletal injury. So within subjects design, but there were a lot of other potential limitations within the study. And this is really the only one that I know of that documents kind of that before versus after injury-prone athlete aspect. And like I mentioned, risky behavior, right? So I think the one on the right, I think Gronk is a good example of somebody that, maybe cares a little bit less about his body on the football field. And so he's more willing to put himself in harm's way, and that could result in getting hit in the head. But then, it could also result in him spraining his ankle or something like that. Apart from all the other discussion we've had, it may just be that those who get injured because they're in risky behavior. I think the rock climbing example on the left is a good one because I would call myself maybe not totally afraid of heights, but marginally afraid of heights. I'm not going to fall from a height that high because I'm not going to put myself in that position. Versus this guy obviously has a ton of skill and has developed that over time, but that's a fairly risky behavior. So I would say that he's probably more likely to at least get injured from a fall from height than I am. And as I mentioned, deconditioning, if they rest, then their conditioning level may be reduced. But I kind of already explained that data from Rob Lionel's study and kind of the theory behind it. I haven't seen anything to really say that that's a really strong theory. When it comes to this perception-action coupling, this is a study from Sean Eagle's paper in 2019 that kind of goes through, more of the neurophysiological dysfunction. So if you have a concussion, you have neurophysiological dysfunction, perhaps that results in some sort of cognitive fatigue. I've kind of not even talked about the ocular system, but that may relate to the concussion may create visual deficits. Those are then contributing to potential dizziness, some sort of mismatch with the information coming in and how you recognize that and execute a motor task to protect yourself from further injury. And so if they have not reestablished that kind of coupling mechanism, that may predispose them to further injury. And so I think another valid theory and something that a lot of people are interested in working on. And then the last of these kind of theories that I was talking about relate to neuromechanical responsiveness. And I think this figure is nice because it really just shows the complexity of all the different things that you have to do as an athlete. As far as your alignment, your postural balance, your vision, how that integrates with motor planning and responses and reaction times and things like that. Excuse me. So this is a paper that Dr. Buckley and I worked on a couple of years ago. And this, again, just kind of outlines what I was talking about initially with neuromuscular control deficits may go undetected. And that's not anybody's fault. I just don't think that maybe we have the tools to allow people to actually measure these things. And again, independent of a concussion, they're modulating risk. So what have we found? Well, we found that if you have somebody do a dual task, so again, in the context of walking and thinking at the same time, take gait speed is the measurable outcome, and you compare how fast somebody's walking while they're simultaneously saying the months in reverse order or spelling a word backwards. That's kind of the simple paradigm that we use. We see that those deficits continue after concussion beyond what we're able to measure with single task deficits, so just walking without a cognitive task, beyond self-reported symptoms, beyond computerized neurocognitive tests, beyond electrophysiologic measured deficits, and beyond return to play time. And I think this last one is, they're cleared to return to play, they go back to sports, they still have some sort of deficit. So then building on that, we looked at, okay, somebody gets injured, they come in, we see them in the clinic. That's this first time point. On the left, we have symptom severity. On the right, we have gait speed dual task cost. So dual task cost meaning the relative change within the individual when they have to walk versus when they have to walk with a cognitive task. So everybody slows down to some degree, or most people slow down to some degree, to accommodate for that increased cognitive load, that cognitive perturbation. And so we assessed them when they first came in, and then we assessed them once they were cleared, after they were cleared to return to play. And then we followed them over the following year and said, did you get a concussion or not? It was retrospective. There's a lot of limitations with the study, but this was kind of the first one where we said, okay, can dual task gait actually help inform some of the theory around why we're identifying athletes who are more likely to get a subsequent injury? And we did see that over the course of recovery, as you can see here, a lower value is worse. That means they're having a more difficult time integrating cognitive and motor information. The group that got a subsequent time loss injury kind of got worse during their recovery. And what does that due to? Is that a regression to the mean? Is that an artifact? I'm not entirely sure. But I think it's an interesting concept to kind of think about. Building on that, Jesse Oldham published a paper with Dr. Buckley as the senior author earlier this year in MSSE, and found that there was some slight kind of I guess an alteration of direction. So this is before they even got injured. She measured gait speed under dual task conditions, and then measured them again at return to play. Those who went on to get a musculoskeletal injury, kind of, you can see that trend where they slowed down at return to play relative to their baseline versus a fairly stable, maybe a little bit of an increase for those who were cleared to return to play and didn't get a musculoskeletal injury in the year after concussion. There was no statistically significant differences other than those who got this group got the musculoskeletal injury. They demonstrated a more conservative gait pattern both before and after. So perhaps there's, like I said, some pre-existing deficits that may or may not contribute. Still trying to untangle those things. So from a clinical perspective, again, we're using kind of advanced sensors and motion capture to quantify these things. But what are some things that you can implement in your practice to kind of understand if an individual may be having some dual task deficits? Well, what we've used is the tandem gait test. And so I think this is another study from Jessie. What she compared was, this is again, baseline collegiate athletes versus acute post-injury, left versus right. And on tandem gait, she found that there was a significant difference where they could not complete the test as fast, acutely post-concussion, versus at a baseline. And for those of you that are unfamiliar, the tandem gait is essentially a time test. You walk heel to toe on a line 3 meters, turn around and come back. So there's at least a measurable outcome that removes some of the subjectivity of something like BESS, which was the comparison here. So if you compare controls over a similar timeline, they demonstrate no change. If we look at the BESS or the modified BESS, no change for either group. Then this is a study that was just accepted, is in press right now from one of our med students here, where she actually looked at, so we implemented the tandem gait test in all of our clinics for the past year. So any kid that comes in and has a concussion would get a single task tandem gait test and a dual task tandem gait test. And this was within the first 10 days of injury. And what we found was that, similar to what Jessie reported, those who come in with a concussion complete the test significantly slower than uninjured controls. I don't think anything too shocking about that finding. If you get a concussion, you're not able to complete the test as fast. That was present in both single and dual task conditions. But what I think is interesting was we're able to derive some sensitivity and specificity measures from these that put some of the results in context. So again, this is the generalizability can be questioned for sure. Within 10 days of an injury of adolescents with sport-related concussion reporting to kind of a specialty care clinic, at the threshold of 16 seconds, so can you complete the single task tandem gait test in 16 seconds? The sensitivity is 88%, specificity is 72%. So at least that provides some context if you're going to use this, that's a reasonable threshold to use as a part of a multimodal evaluation. Certainly not the only one. And then for the dual task tandem gait, the cognitive test being saying the months backwards, reciting or spelling words backwards, and subtracting by sevens from a random 2-digit number while they're doing the tandem gait test. It takes about 22 seconds, and that was a nice cutoff to demonstrate 85% sensitivity, 72% specificity. So perhaps these are some things that we can implement in our clinics on a routine basis that might help inform some of the information about whether or not somebody's still demonstrating kind of combined cognitive and motor impairments. So from point 2, I think it's complicated, it's multifaceted. I don't think that that's shocking to anybody, but we don't have a super clear perspective right now. I think that we still are on that step 2 of the why, and what are the factors that we can identify, because we need to identify what's responsible for this increased injury risk before we're actually going to, really do effective interventions. But thinking about your return to play stepwise protocols, incorporating these assessments for future injury risk may be something worth considering. And so in the last 5 minutes or so, I kind of want to just talk about some of the work that we're doing. I just mentioned that we don't really know how to intervene, but there are some things that we can kind of borrow from other areas of literature that have demonstrated effective injury risk reduction to actually identify, okay, now what do we do with this information? We know this phenomenon exists. We have some theories about why it's existing, but today, are there things that you can do to help reduce the injury risk for your athletes? So there's a lot of well-established neuromuscular training methods that have emanated a lot of the work out of the University of Cincinnati and Cincinnati Children's Hospital with Greg Meyer, Kim Barber-Foss, and that group really identified that if you implement some neuromuscular training programs among teams of different youth sport athletes, you can reduce knee injury rates, ankle sprain injuries, specifically in youth soccer and basketball, is what they found. It's relatively easy to administer. It takes about 20 minutes or so, and it usually requires a qualified health professional to do it. But it really relies on things like plyometrics, strengthening exercises, technique training, all that kind of good stuff. And there's a really good paper that outlines every single progression of different exercises to do in 2008 from Greg Meyer. This is just one example of a lateral jumping progression. So, you would do a lateral jump and hold, and then lateral jumps, and then a hop and hold, and then hops, and then, proceed from there. So kind of building upon itself, these progressive steps to improve strength, skill, landing mechanics, all the things that we know contribute to injury. So what we did was we actually have a pilot kind of randomized control trial where we started individuals with this neuromuscular training program within about 11 days. One patient, it took a full month after they were cleared to return to play after their concussion. We said, can we actually intervene and do something to reduce this injury risk? It takes about, so we did about an 8-week intervention. They met with an athletic trainer 2 times a week, and there was only 11 of them. So I don't have, this is all very preliminary and unpublished or in review. And the mean number of sessions they completed was about 14 out of a possible 16. So again, meeting for 8 weeks, 2 times a week with an athletic trainer for about 20 minutes. You can see here 18.2 minutes on average. That's all that it took. And some of our preliminary data on the follow-up. So again, the kind of design of the trial is we have individuals come in, we recruit them, we follow them until they're cleared to return to play. We start this intervention for some. We randomize them versus kind of usual care, which is just go back to sports. And then we follow them for the following, right now, up to 6 months post-injury. And at 6 months post-injury, we're asking them every month, how much did you participate in sports, and did you sustain a sport-related injury? Obviously, this trial has been disrupted quite a bit by COVID as far as exposure rates go, but we do see that those who have completed the neuromuscular training programs, 18% of them, so 2 out of 11 have gone on and sustained another injury. So 18%, not too bad, versus 63% who completed standard of care, meaning they didn't do any sort of intervention, sustained a sport-related injury. So 63% is a little bit high, quite a bit higher than what's been published. So I don't know how much strength to put in these findings. Again, they're very preliminary. I wouldn't put a whole lot of strength in them, but I think it demonstrates the point that this is a feasible intervention that has some theoretical backing, and the results thus far are pretty good. We're going to wait for the full year. We kind of did an interim analysis at 6 months last month. So we got about 5 months to go of prospective injury monitoring before we're actually able to run with this, and we'll see what happens. One note was that they did have similar injury exposure, so it's not like the standard of care group was just participating in more sports. So there may be some benefit of continued injury prevention training after concussion return to play. So in summary, concussion leads to a higher MSK injury risk. There's measurable deficits in a lot of different domains that may modulate the ability for somebody to prepare themselves and protect themselves from further injury. And again, it's a multifaceted problem. I don't have all the answers, but hopefully we've started to kind of poke around the right areas. It's pretty low risk beyond some of the time elements to try to understand how we can do some neuromuscular training and maybe how we incorporate some attentional training. I know other people are working on vision training. There's a lot of things that we could potentially do that have very little risk of harm, that may be beneficial to these athletes in reducing that injury rate following concussion. So this is where I am. Well, not today. I'm at home today. This is where I normally sit, at the hospital right there. You can find me on Twitter, email me, happy to talk more. And thank you for all of your attention. Hopefully people are still awake, as Dr. Buckley mentioned.
Does anybody have any questions for Dr. Howell? Either in chat or on mute.
Yeah, David. It's Brian.
Brian.
Listen, do you read out or consider psychological aspects in terms of hesitation? You know, athletes following a traumatic brain injury or concussion, recovery from concussion, return to play, and they seem fine, but there may be some psychological aspects in terms of them hesitating in high contact or avoidance of others in that situation on the field, subconsciously maybe?
Yeah, it's a really, really good question. So we are considering that and we're measuring it. I don't have an answer as far as relation to further injury, but I do know that, so there's one study that was published, I think last year, that kind of documented for the first time that after concussion, athletes have a high fear of movement or fear of pain with movement, using something called the Tampa scale of kinesiophobia. It's pretty common in the ACL literature. And we're using that approach as well. And what we're seeing is that, yeah, there's a lot of hesitation and fear that goes into this. And that may be something that is also kind of modulating their risk of further injury. That if, for whatever reason, whether it's the topics that Dr. Buckley was just talking about, they're afraid that if they continue playing, that they're going to have long-term brain damage, or there's some sort of hesitation that they're not as confident in how they move, which I think that's what we're understanding, particularly after concussion. That may be a factor. So yeah, so yes, people are looking at that. I don't have a great answer at this point, though.
I actually have a question on the times for the single task and dual task. You said those were done with high school age kids. Yep. How would you expect the baseline times or the standard deviation times to change with older populations, with college or adults, and also with younger youth sports, middle school, so on and so forth?
Yeah, that's a good question. So again, yeah, what we measured was athletes who come in to our clinic within the first 10 days of injury relative to kind of general run-of-the-mill high school students, right? And so those are kind of the thresholds that we've started to apply. 16 seconds, for example, that tends to give us a pretty good yes, no, not great, not perfect. But the thing to consider is that, are you testing in the collegiate athlete population, for example? Are they collegiate like varsity athletes, or are they club sport athletes, or are they not an athlete, right? So all of those like things go into skill acquisition and the ability to perform a motor task. So yes, there appears to be an age effect where as you get older, you get a little bit better at doing these things. But at the same time, I think that, you know, for example, you know, the work that Dr. Buckley and I have done on this in collegiate athletes has been primarily from the University of Delaware and the Harvard student athletes. And so we can't really extrapolate what the cause of a better time is. That just age, or is it kind of a self-selected bias where those who end up playing collegiate sports are just naturally better? So we have not developed those same thresholds just because we don't have that volume of data at this point, but it's certainly something that we're looking at. I would expect that, you know, something like 14 seconds has been proposed as a good cutoff for the tandem gait like single task test. So it's full 2 seconds faster than our high school cohort. The thing to consider with that is we do see a fair amount. I think in one paper we showed maybe a 3% false positive rate with that. So a healthy person can't, about 3% of healthy collegiate athletes can't even complete that test in less than 14 seconds. So identifying a firm threshold is challenging, but I do think that as people get older and into, you know, even I've had conversations with some of my colleagues here from the U.S. Olympic Committee, and they're finding that the tandem gait test actually isn't super valuable because they're all so good at just, you know, these really highly trained Olympic athletes. There's a pretty big kind of basement effect where everybody's doing it really fast, and they're even able to do it after a concussion because they're kind of again, motor-wise, a lot more advanced than the high school kids that we're seeing.
Thank you. Does anybody else have any questions for either Dr. Howell or Dr. Buckley about anything that we've heard today? All right, I think we are good to wrap up here. I'm going to put the evaluation and assessment in the chat again at the bottom. Again, the evaluation is optional, and the assessment, when completed 80% correct, will give you your statement of credit for the course. Thank you so much to everybody for joining us today. Thank you, Dr. Buckley, Dr. Howell, for taking the time to speak with us. This has been really wonderful, and we really appreciate it. I hope everybody has a wonderful rest of your day, and stay safe, wash your hands, and wear masks.
Thanks for the invitation. This is fun.